Thank you. So good evening to all the clinicians. On behalf of INTA's Zenit team, myself, Dr. Nishan Dalal, would like to extend a warm welcome to our virtual forum called Nephro Live. The Nephro Live is our unique monthly webinar, which intends to deal into various critical aspects of kidney disorders, which are of significant relevance in the day-to-day clinical practice of Indian busy physicians. And each session will feature a distinguished panel of experts discussing about latest developments and best practices with regards to kidney disorders. Here, I would like to highlight that this time we are excited to bring you something different. We have shifted to more dynamic talk show based format with this new model, we are optimistic that it will help us in fostering more deeper discussion, allowing for more interactive discussion, and providing the answers to the real world challenges that Indian clinician faces in their day-to-day practices. And for this, we are quite honored once again to have Dr. Dinesh Khullar, a luminary and iconic figure in the field of nephrology with us as a course coordinator for this entire webinar series. And today's inaugural session will deal with CKD challenges and best practices in diagnosis. And for this also, we have the luxury of having the galaxy of eminent nephrologists from all parts of the country. As always, to the audience, my request would be, we request for your active participation. So do post your question, do post your questions. We will address everything with our faculties. So with this, let's dive into the exciting first episode of Nephro Live. And for that, I would like to introduce and invite Dr. Khullar, course coordinator for today's forum. So, sir, I believe does not need any introduction, but as the customary, I will very like to briefly introduce sir. So, sir is the chairman and head Department of Nephrology and Renal Transplant Medicine at Max Super Speciality Hospital, Saket. He is the executive council member of the ISO 2023-24, past president Delhi Nephrology Society, and he has some pioneering work that I'm quite honored to highlight here. So, he has the pioneering work in the field of induction therapy in renal transplantation, first one to adopt the concept of hemodiafiltration in North India, involved in over 5,000 successful kidney transplants, including a large number of ABO incompatible, highly sensitive and challenging transplant. He is very keen interest in the academic work and also the founder program, director of DM nephrology in the neighboring country of Nepal. He has various publications and various awards to his credit. So with this, I would like to hand over this virtual forum and the virtual podium for the inaugural edition of this Nephro Live to one and only Dr. Dinesh Kullar, sir. Over to you, sir.
Thank you very much indeed, Dr. Nishant, for that very kind introduction. So I think I am, first of all, would like to express my gratitude to INTAS for giving us this platform to be able to connect to the physicians across the country whom we believe would always want to refreshen their knowledge about the various specialities, and nephrology is no exception. So I certainly, as you can see, I'm quite excited from what we are going to have over the next 1 year. The first edition of this kind of interaction was hugely successful, and I thoroughly enjoyed it during the last little over a year ago. And that was very, very informative, very useful, at least to me, interacting with so many of the luminaries as nephrologists across the country, learning from them, interacting with them. And I'm sure the kind of knowledge we collectively could disseminate during the course of that edition must have immensely helped everyone of those who had joined us and were in regular touch. We got great reviews, and thank you very much for those of you who were part of the previous edition as well. So this time, as you can see, as has been highlighted by Dr. Nishant, we have changed the format a bit. We will try to be little differently and innovatively coming to you, presenting to you the best kind of knowledge which we have in the contemporary world of nephrology. And as you can see, it's the topic is CKD and the challenges and best practices in diagnosis today. So what the format today is going to be, I'm going to first request a brilliant nephrologist, and I'm honored to have him as a colleague in my department, and that's Dr. Kulwant Singh, who is currently working as the principal consultant nephrology, Max Super Specialty Hospital. He's had a brilliant academic record whereby after his post graduation, he did his DNB in nephrology from Sir Gangaram Hospital way back in 2010-11, and it was a matter of pride to see Dr. Kulwant Singh come as the best nephrology candidate, and he was the gold medalist, where he topped the country in his nephrology examination. So after this, he worked for many years in Chandigarh and Mohali, and just about a little less than a year ago, he has moved to Max Hospital, Saket. He has published many research papers. He's a very keen academician, has a lot of interest in research activities, in publishing a lot of research material, and he's been a very sought after presenter at various conferences, both at the national level as well as internationally. So he has some areas of interest within the field of nephrology, but what he's going to talk to us today is about the kind of challenges which CKD can throw to us when it comes to making a diagnosis. So we will get started with today's program, and this will be our journey of next about a year or so, or maybe even longer than that, trying to cover as many aspects and facets of chronic kidney disease as possible, and trying to bring home to the audience what is new in terms of the diagnosis, in terms of the challenges thrown by the disease, and of course the way we as a medical fraternity have found ways to circumvent or mitigate the challenges and come out successfully and trying to add to the value so that's one. Subsequently, in the next few editions, we will touch upon the various aspects of the chronic kidney disease and then talk about their management as well. For today, so it is going to be Dr. Kulwant Singh talking, giving us a brief overview of what we will further be interacting with our elite panelists, and I will take this honor of introducing them after Dr. Kulwant has given us. Over to you, Dr. Kulwant. And I'm sure, ladies and gentlemen, you will find this over information we are actually able to disseminate over the next 1 hour to be very, very useful, because you couldn't have asked for better panelists than what we have been able to rope in for this opening edition of Nephro Live. That's the name which we have given to our year-long program. And I would certainly like to thank INTAS, spearheaded by Mr. Amit Arora, who has been very, very keen on bringing academics to the forefront, and ably assisted by his team, Dr. Nishant, Gaurav, and I'm sure that know them by their names, but I'm sure they have done a wonderful job. And the beauty is, Intas will not want to promote any of their products here. It's almost like a pact that we are going to focus purely on academics rather than. Thank you very much once again, Intas, for this wonderful initiative. Over to you, Kulwant. Thank you very much.
Good evening, everyone. Am I
Yes, you're perfectly fine.
okay? So first of all, good evening, everyone, and I would like to thank both Dr. Kular sir and Intas Pharmaceutical for giving me opportunity to present this inaugural talk of Nephro Live. And you must be knowing that this topic is very important, or you can say this is a founding stone for our future discussions also. So I would like to be go little slow so that all our physician colleagues imbibe things very slowly, and I'm sure the panelists at the end will discuss all the doubts by the audience also. So to start with the talk, we all know that CKD means chronic kidney disease. So, but when I was making these slides, I actually thought it should be better labeled as challenging kidney disease, because there is a challenge to assess the exact prevalence of the disease in the society. there is challenge to diagnose the disease at the early stages, and there is challenge again in the management part also. So in introduction, the true incidence and prevalence of CKD are challenging to determine due to the asymptomatic nature of disease in the early stages. In worldwide, the prevalence of CKD is around 10% to 14%. In India, various studies have shown that prevalence ranges from 10 to 17% in our population. So this first line is taken from the article of Dr. Varghese et al. From CMC Vellore, where they showed that almost 50% of the patients, when they first time present to the physician, are already in stage 5. So this is very alarming figure. And the second line of this slide is taken from the presentation from Dr. Vivek Kumar from PGI Chandigarh, where they highlighted that the cohort which they studied in CKD people, the 2/3 of the population were from the rural area. So it's not the disease of the urban region. Almost majority of the people were coming from the rural area. So we need something, some point of care testing so that we can diagnose these patients at far-flung areas at early stages. Also, the 73% of the people were having some kind of formal education. So it's not that people were uneducated and they could not pick the disease or the symptoms at the early stages. So even the disease is suddenly occurring in the educated people also. So in definition, we define CKD as a structural or functional abnormalities of the kidney when they are present for 3 months, manifested by either kidney damage, like which is shown by some histopathological abnormalities, or when there are some abnormalities in the urine, abnormalities in the blood, like acidosis in renal tubular acidosis, in abnormalities in the imaging, kidney transplantation, or end when the GFR is less than 60 ml. So this is basically the definition of CKD. So there are two things. One is the definition and the other is the classification. So definition verbatim, as I have already mentioned, is the abnormality of kidney structure or function which is present for 3 months. This is very important with the implication for the health. Whereas the classification is based on three things. One is C. C stands for cause, whether the disease is due to diabetes or due to interstitial disease or any glomerular disease. Then G stands for what is the glomerular staging, and A stands for. Earlier, we used to stage GFR in 5 subsets, but now the stage 3 has been sub according to the GFR, whereas albuminuria has been classified into 3 classifications, A1, A2, and A3. Earlier, we used to use when the albumin is more than 300, which is now termed as A3. Microalbuminuria, which is now absolute, we are now using A2 when the albumin is between 30 to 300 milligram per gram. Now, here it is important. A1 is when the albumin is less than 30, but it doesn't mean the albuminuria is normal. It is normal to mildly increased, because now the newer studies are taking the baseline value of albumin to even lower. Some are taking normal albumin to less than 20, and some are even stricter where they have taken the albumin levels to less than 10 milligram per gram. So by this classification, we generally classify our CKD according to the latest KDIGO classification. So when we plot the GFR and albumin, we get this type of colorful chart, which is known as a heat map. So here, the people who are in green region are basically low risk, which only requires screening. In the yellow region, the people are moderately increased risk. Orange are high risk, and whereas red are very high risk, which directly needs treatment. So as we move from yellow to red, it means the risk of kidney failure increases. So patient who is having GFR of 20, or you can say he is in a stage 4 CKD, the risk of kidney failure in next 2 years is more than 40%. So even if we extrapolate these heat maps to other diseases like all-cause mortality, cardiovascular mortality, the risk of incidence of newer MIs, strokes, heart failure, the risk increases as the stage increases. So people who are in the red zone or CKD stage 4 and 5 are at high risk of developing these diseases or these mortalities. So this was our basis of CKD. Now coming to our core slide regarding the diagnosis and best practices in the chronic kidney disease. So when we talk about the diagnosis, the first thing which comes to our mind is the GFR. GFR means glomerular filtration rate. It is considered as the best overall assessment of kidney function, but mind it, the term kidney function should not be used synonymous with the GFR. Because kidney function is not just only GFR, it reflects the entirety of different and complex physiological functions of the kidney. So there are n number of functions which are played by kidney apart from just glomerular filtration rate. eGFR, which we commonly use, is an estimated GFR. It basically estimates the exact or the measured value of GFR. The normal GFR varies according to age, sex, and body size, and it declines with age. So these are the methods how we evaluate for GFR. Either we go with the estimated GFR equations, or we go with the measured GFR where we inject something into the body like iothalamate, and then we calculate its plasma or urinary clearance. We can go for a timed urinary clearance of the creatinine, like we go for 24 hours creatinine clearance in urine, which can give us a rough estimate of the measured value of GFR, or we can go for a DTPA scan, which are not recommended for measurement of GFR, but there for other purposes, like when we have to take a call which kidney has to be removed in a donor nephrectomy, or sometimes when a kidney is non-functioning, whether to remove the kidney or not, or to know the split function of the kidney, that time we go for the nuclear imaging testing like DTPS scan. So first coming to the eGFR based on the creatinine equations, according to KDIGO latest classification, which was published in 2024, they say that the initial assessment should be based on the levels of creatinine. We should go for the creatinine estimation, and on the basis of the CKD EPI equation. There are other equations also, but this is the most preferred equation, CKD EPI 2021 equation. These are readily available on various forums like NKF, Up to Date, etc., where you can have the calculators. We can easily calculate eGFR for you by just putting the creatinine values. So this can give you us the initial assessment of the GFR. But we should always know that there are some limitations with the creatinine based formulas, because in cases like acute kidney injury, creatinine is not in a steady state. Creatinine is based on the muscle mass of our body. If a person is having a larger muscle mass, or a patient is having a muscle wasting disease, then that time creatinine values will be higher in our body and it can falsely give us a low GFR. Similarly, if some drugs are competing with the secretion of creatinine in the tubules, like Septran is there, cimetidine is there, they can give us a false high creatinine value and a low GFR. Some drugs interfere with the assays, not the enzymatic one, but the older assays like Jeffe's method, bilirubin, which can interfere with the assessment of creatinine and can give us a false low levels of creatinine and thus a higher values of GFR value. So whenever such limitations are there, then we go for a second test, which is known as cystatin C. So basically, cystatin C is a protein which is expressed by all nucleated cells. Its production is constant and it is freely filtered by the glomerulus. But KDIGO recommend that we should use as a second test in the clinical situation when we feel that our creatinine based estimated GFR is less accurate, and we need a more accurate GFR assessment because it affects our clinical decision making. Like a lady is there who is 90 years old, she is in our ICU, she is very flare, very cachexic, weight is hardly 35 kgs, but the creatinine is 0.9. So if we are using creatinine based formula, we will get a falsely high value of GFR in such patient. So whenever we have to assess the eGFR for various reasons, like for our antibiotic dosing, in that set of patient, that this cystatin C will be more helpful. But in this guidelines, KDIGO recommended that we should better use combination of creatinine and cystatin formulas for eGFR, because as creatinine is directly linked to muscle mass and it has various issues with the patients who have sarcopenia, amputation, and spinal cord injuries. Similarly, cystatin C is also impacted by different variables. Like in the patient who are having a steroid use, the levels of generation of cystatin C will be low. Whereas in the patients of cancer, wherever the disease turnover is high, the value of cystatin C will be falsely high. So in such patients, we are not dependent on either creatinine or cystatin because they are not reliable. We should better use combination of creatinine and cystatin. The formulas are really complex. It's better to use calculators which are readily available on all the internet and other portals. After that, after the estimated GFR, we come to measured GFR, which is measured, as I earlier told you, by either by the plasma urinary clearances of the exogenous substances or by the timed urinary estimation of the creatinine clearance. So this in a nutshell, whenever a patient comes to us first time, we should go for creatinine-based eGFR. If we feel that this is not accurate or there are different variables which are affecting the creatinine values, or we need a accurate eGFR for some purposes, we should go for cystatin C based equations. And even if after both these we are not satisfied and we need more accurate GFR assessment, then we should go for a measured GFR to assess the exact GFR for that patient. Apart from GFR, second thing which we are dependent on the value of albumin in the urine. So albuminuria refers to the abnormal loss of albumin in the urine, which is more than 30 milligram per gram. Albumin is one of the type of plasma protein which is found in the urine in normal subject and in larger quantity in the patient with the kidney disease. In the KDIGO, earlier guidelines which are published in 2012 regarding chronic kidney disease, they focus particularly on albuminuria rather than proteinuria. And this albuminuria was basically used to stratify their risk stratification. Proteinuria is important in subsets of patients where there is secretion or excretion of non-albumin based proteins, like patients with multiple myeloma or a light chain disease, where non-albumin things are coming out in urine. But for risk stratification, KDIGO has focused particularly on the albuminuria. So in the order of preference, KDIGO recommends that we should go firstly for urine ACR. If that is not available, we should go for reagent testing of albumin by dipstick, which should be read by the automatic method. If that is also not available, then we should go for UPCR and then for the reagent testing of the total proteins in the urine. Whenever the reagent test is positive, we should go for the quantification by ACR, PCR or 24 hours urine analysis. And whenever there is a positive test in the ACR on the incidental finding, we should go for a first morning void sample in the midstream urine sample to assess for the exact ACR. And we should also know the factors which affects our ACR or PCR values, like a patient who is having hematuria, in the menses, in the exercise, in the infection, there is increased albumin values in the urine. So it will falsely elevate our ECR or PCR value. Similarly, in females, on the patients who are having a lower weight, the levels of creatinine excretion will be low. So if the denominator will be low, we will get a falsely higher values of ACR or PCR. So in such scenarios, it is generally recommended that a 24-hour sample should be done for the definitive measurement of the presence or absence of the albumin. Apart from the measurement of urinary albuminuria, we should also look for any RBCs are there in the urine which suggest of any activities. We should see the pH of the urine. We should also look for any cast or crystals. Now coming to the third point, which is point of care testing. Point of care testing may be used for the assessment of creatinine and urine albumin measurement where access to the lab is limited. It is very helpful in critical areas like in our emergency triage, in our ICUs, and also very important for the remote locations. You won't believe that there are areas in Himachal like upper belts of Kinnaur, Spiti, and in the areas of Kargil and Ladakh where people in today's era also have to travel 3-4 hours just to give their sample. And then that sample reaches Chandigarh or Delhi and they get even the report of creatinine in 3-4 days. So especially in that areas, these point of care testing can be very helpful. So these are the few devices which has been validated by KDIGO like STAT sensor, iStat and ABL. So these are basically a glucometer like devices where by drop of blood test, they can assess the level of creatinine. So there are other devices under validation also where creatinine assessment can be done by a saliva also. So I think these things can screen at least patients at these remote locations early and can help the patients to get an early diagnosis and get the treatment early. So apart from that, few other things which help in our imaging are in diagnosis are the imaging modalities like ultrasound, CT scan, nuclear methods, which can help us to assess the kidney structure, like what is the shape, what is the size, even if when the size and shape are normal, what is the corticomedullary differentiation, whether there is the evidence or obstruction. Apart from diagnosis, these imaging also help us in the treatment part. Like in cystic diseases, we go for height adjusted total kidney volume by MRI scan, which help us to know the progression of that cystic diseases, whether we can start the drugs like tolvaptan in that patients or not. In reflux disease patient to stratify what kind of reflux they are having, what is the stage, whether we should go for only medical management or we should plan some surgical management in such patients. Kidney biopsy, as per KDIGO, is recommended. It is a most acceptable, safe diagnostic test which can help us in the exact diagnosis, planning treatment to assess the activity and chronicity and likelihood of the treatment responses in such patients. There are some serology and biomarkers also which help in the diagnosis, like anti-PLA2R, which can help in the patients of membranous GN, ANCA, anti-GBM, which can help in vasculitis, serum free light chain assay, serum protein electrophoresis, which can help in the patient of plasma cell dyscrasia. There are biomarkers which we can assess in the urine, which can help in telling us about the progression of disease, like ADMA, asymmetric dimethyl arginine, or urinary epidermal growth factor, which can tell us about the progression of the disease, TGF beta 1, FGF23, which can help us to know, understand about the fibrosis of the disease. We also sometimes need genetic evaluation for evaluation in the chronic kidney disease, especially in the patients who are going for transplant, where we are suspecting that the disease can recur after transplantation, like atypical HUS, primary hyperoxaluria. In choosing our donors, like a patient who is having a family history of cystic diseases, where we want to choose a safe donor, there we go for the genetic analysis. In the conditions where there are specific disease modifying therapies available, like in Fabry's, like in cystinosis or some tubulopathies, in such cases, these genetic evaluation aid to our treatment modalities. So in nutshell, apart from physical examination, apart from proper history taking, GFR assessment, urine analysis, we need sometime ultrasound, kidney biopsy, and just genetic testing to make the diagnosis of our patient. Apart from making diagnosis, in these guidelines, KDIGO has given more importance for the chronicity evaluation of a patient. So proof of chronicity means that whenever the disease is present at least for 3 months, so we should review the past records of the patients, his past estimated GFR, past records of creatinine, albumin, and proteins in the urine. We should try to find out chronicity by imaging methods, like sometimes the kidneys are already shrunken, cortical thickness is decreased, or CMD is lost totally. That shows chronicity on day one of the diagnosis only. Or the kidney histopathological finding, which can tell us about the tubular atrophy or fibrosis, taking the proper history, or indirect findings like anemia is there, PTH is high, that can tell us about the chronicity of the patient, so that we don't have to wait for 3 months to label him as CKD. We can start the treatment, precautions, prevention, screening, everything of chronic kidney disease on day one only. So take home message is that classification of CKD is not to label somebody with CKD 1, 2, 3, 4, 5. It is to identify high risk patients so that we can do a regular screening in that patients. In patients who are having diabetic, old age, some ladies who had preeclampsia or eclampsia in their pregnancies, patients with history of acute kidney injury in the past, they should be screened regularly with the urine analysis, measurement of their urine ACRs, creatinine level, and estimation of GFR by using CKD EPI 2021 equation. Whenever we get an incidental finding of elevated urinary ACR or any other hematuria or low GFR, we should repeat the test to confirm the presence of CKD. Whenever cystatin C is available in your lab, try to measure creatinine and cystatin C with the same sample and try to follow the combined eGFR based on creatinine and cystatin C formulas. We should always look for proof of chronicity so that we don't delay the treatment and start the treatment early. We should use the heat maps so that we can not only find the progression of a disease, but also we can detect the cardiovascular or the cerebrovascular event in our chronic kidney disease patient. So I end here with thank you, and over to Dr. Kular, sir.
Well, thank you very much. And I'm sure everyone would agree that this is a very nice overview of what we are going to discuss over the next about half an hour in the presence of the best possible panelists. At least I could think of the opening edition of this second of its kind. with the support of Intas Pharmaceuticals. So, well, Dr. Kulwant has given us an excellent overview, as I said, of the way we approach a given case of chronic kidney disease. I'm sure there are a lot of ambiguities in everyone's mind, and we have tried to evolve. Gone are the days when we were using the statements like ARF and CRF with a lot of, I would say, ambiguities. Not any longer. We are evolving. I'm not saying the final word is out, but we are a lot better than where we were till many years ago. So to discuss that, and as I said, this is the opening round where we'll be limiting our discussion to making a diagnosis of chronic kidney disease. I am sure an average physician in our country is lot better than where we stood just about, I would say, a few decades ago, not for any other reason, but the sheer enhancement of knowledge by various kind of facilities thrown open to us, and especially what the way the internet has changed our access to the knowledge dissemination is concerned. So for that, I'll have the pleasant task of introducing today's elite panelists. I would first be introducing Dr. Sonal Dalal, who is a very respected figure in the field of nephrologies across the country. She's a senior consultant nephrologist and a transplant physician based out of Ahmedabad. After doing her DNB in nephrology from the prestigious IKDRC Ahmedabad way back in 2000, she has been working as head of the department of nephrology at the famous Sterling Hospital Ahmedabad, and she also is the director of the Gujarat Kidney Foundation, who are doing a stellar work, playing a big role in the promotion of nephrology services. So she has many nephrology publications, both at the national and international levels, and it's always a treat to listen to her and interact with her in any of these national conferences that we have been interacting in the past. Thank you very much, Dr. Sonal, for joining. I'm sure the audience is going to be wiser with your pearls of wisdom today. Out next, I have the pleasant task of introducing Professor Arvind Gupta from Prayagraj, Allahabad, professor and head of nephrology at the MLN Medical College, Prayagraj, and a very popular and famous nephrologist of Allahabad in that part of Uttar Pradesh, who and at the national level as well, who has significant achievements in the field of nephrology over his vast experience as a nephrologist of many decades, whereby he has received many international awards. He has been organizing many CMEs very, very effectively, and he has been a prominent contributor towards the field of nephrology at the local as well as the national level. Large number of publications in both the national and international print media, and he has a few books to his credit as well as book chapters. And I'm sure the immense experience which Dr. Arvind Gupta carries with him is just appropriate to guide today's audience about the nitty-gritties of making the correct diagnosis. Gone are the days when we were just talking about AKI and CKD very loosely. Now you're very precise and specific, and we'll come back to that when we have Dr. Arvind Gupta join us in the discussion. Up next, I am delighted to introduce my dear friend, Professor Muhammad Ashraf Bhatt, who is the professor and head Department of Nephrology at the Sher-e-Kashmir Institute of Medical Sciences, Srinagar, popularly known as KIMS. He is another brilliant nephrologist that have come across over our many, many decades of close association. It's always a treat to interact with him. He's been a guide for his DM students and been a co-supervisor for PhD students, helping them in their thesis, and has been an assessor as well, and is a guide to the MSc hemodialysis candidates as well as a reviewer in the peer-reviewed journals. And again, he has been an author of many important national and international publications in the various journals of repute, and he's a member of various societies. Again, warm welcome to you, Dr. Bhatt, and I'm sure the audience today is going to become wiser with your presence as well. Up next, and our last panelist for today is a very dear friend, Dr. Rajashekar Chakravarti from Hyderabad. He's a clinical director and head of the Department of Nephrology and Transplant Services at the prestigious Yashoda Hospital, Hyderabad, India. And he has a rich experience of many decades in the field of nephrology. He is a very, very prominent figure at the national level as well as internationally. And what we both of us have in common is our common interest in the CRRT. He has really invested a huge amount of time and energy promoting continuous renal replacement therapy in the country, whereby he's been organizing regular conferences, fantastic conferences over the years, promoting a very, very important modality of treatment in the critically ill patients. He was, as a matter of pride, that he was one of the representatives from the country when it came to forming the KDICO guidelines on AKI in 2019. He has many publications in various journals of repute, and he's been a reviewer, and as well as he's a chairperson in ISI and IO, American Nephrology of Indian Region, AKI committee. So it's always a treat, the kind of persona he commands, and the kind of knowledge which he disseminates is amazing. And I think, as I said at the outset, it's I'm quite excited to have at least the best possible elite panelist for the day today. So let's get on with some great discussion, which I'm sure is going to follow now. And my opening question would be to Dr. Raj Shekhar. So Dr. Kulwant has given us an excellent overview. And I think he has talked very effectively, highlighting the importance of both GFR, estimated GFR, and albuminuria. So first, the brass tacks. Raj, before I forget, I would like to wish you a very happy birthday. I know it's your birthday today, and you were kind enough to oblige us by your presence. I think I couldn't have asked, but on behalf of everyone who has joined us today, wishing you many happy years ahead, and have a great birthday today. And sorry for this brief interruption, but then this is going to be extremely useful to the people who have joined us today. So when, Raj, would you label a patient as confirmed CKD? Because we have been using this term very, very loosely. We'll say, okay, ये AKI है, ये AKD है, ये CKD है. But when will you say that, okay, look, this person has CKD?
Dinesh, thank you so much, and thank you for the kind wishes, and thank you for including me in the program. That's a very relevant question, and after listening to the presentation, I'm sure all of us are wiser as what KDIGO today tells us is the definition. So, as Dr. Kunal clearly told, there are two parts of making a diagnosis of CKD. One is the kidney function, wherein you use either a creatinine or a GFR. So if you take an isolated GFR, you have to have a GFR of below 60 to make a diagnosis of CKD. Whereas if you take a abnormal anatomy or protein loss, in the presence of these, you can label as CKD stage 1 if somebody has below 90 ml. So if somebody has a lot of protein loss, but the GFR is above 90, we can label it as CKD stage 1. But if somebody comes to me with just a creatinine of 1, I would hesitate to label them. I want a repeat test. As he said, there is a proof of chronicity. As you know, in India, there has been data published. Our GFR may not be the same as the Western GFR. So going by just a single value of GFR estimated may not be the correct way, and we may be over-diagnosing or unnecessarily diagnosing somebody as CKD. So I would want to clearly convey, you look at the anatomical changes, like let us say somebody is born with a single kidney. I would be justified in calling him as CKD, irrespective of the GFR. But otherwise, I want proof of protein loss and then, of course, estimated GFR, which all of us are very comfortable with CKD epi formula today. And even in Hyderabad, there are many labs. When you ask for a creatinine, they automatically give you a estimated GFR. So the short answer to that question, please look at your patient in detail, look at the serum creatinine and the estimated GFR, quantify the protein, and get an ultrasound to see if there is any change anatomically in this patient. Thank you.
Quite appropriate, Raj. I would totally agree with you. And I think just I would like to add on what Kulwant also tried to show in his slides, that we should do away with the older terminology. And I think it's high time it's not just the responsibility of us as nephrologists to speak the way we are supposed to, or defining the disease entity the way we actually should be. I think it's the collective responsibility of each and every physician to be as thorough with the terminology and the changing terminologies as possible. So gone are the days of microalbuminuria or macroalbuminuria. So one thing which I would want to also add is A1, A2, A3, which he has shown. Now A1 can actually be further subdivided. So I think the message which I would want to convey today is it's only less than 10 milligrams of albuminuria in a day, which is normal. Even between 10 to 29 should be viewed with suspicion and should be called as high normal. Okay, you may say that this is looking like normal, but it's high normal. That's the message I would want to convey. And certainly 30 to 300 to 99 is moderately increased albuminuria, and more than 300 is severely increased. The word to be, the emphasis should be on severely increased. It is like waking up someone from this deep slumber, that look, wake up, you have a severely increased albuminuria. It's high time you do something. Fortunately, we have drugs which can make a huge difference. But before we jump on to any kind of medical therapy, it is time that we first understand the gravity of situation. But at the same time, what you have said is equally important. We should not use the terminology loosely, because we know if once we have labeled someone as having chronic kidney disease, it actually means, unfortunately, an irreversible damage. And we know it's a progressive damage at the same time. Yes, we can make a difference, but then once you've labeled as CKD, we know that, okay, this person may not ever get a normal renal functions ever. And the message which can be derived is, if you are not very correct in your diagnosis, look at what we can actually infer. There was data from our country which says that the prevalence of chronic kidney disease could be as high as 16 to 17%. We are a nation of over 140 crores. Look at what this means. Good 25 crore of Indian population has chronic kidney disease. So I am not denying, I'm not contesting it, but what I'm saying is 25 crores is a huge figure. It is more than many countries put together. So before we start believing that yes, 25 crore of our Indian population is having chronic kidney disease, we better be sure as to where we are labeling them as chronic kidney disease. And that is why we have evolved. There is no point shirking away from our responsibility that, look, this is a job of a nephrologist to find out whether it is CKD or not. We have not even heard about cystatin C. Why should even be talking about cystatin C? But the thing today, and as a sincere request I would want to make to everyone, is that, as I said earlier, it's a collective responsibility. There is no point shirking away from learning about the newer concepts of including cystatin C or including GFRs, which are incorporating both creatinine-based GFRs and cystatin. But that's little futuristic. Let's come back and try to ask as to where we are today from Dr. Sonal. Which parameter, Dr. Sonal, would you give more importance to from the two which Dr. Raj has talked about, EGFR or albuminuria? In terms of knowing where we are today and which way we are headed for.
Good evening. Good evening, everyone. Thank you, Dr. Kular, for having me. And thank you, Intas, for organizing this CME, which is a very important clinical topic. As far as albuminuria versus EGFR, what is more important? As we all know that like more important cause of CKD is diabetic kidney disease. And that is the most, like almost 40% of the chunk of CKD burden is because of the diabetes. And the earlier to get involved is the proteinuria. So as we have in our majority of the patients, early stages of DKD, the stages wise, it is like our microalbuminuria followed by overt proteinuria, and then there is a declining of GFR. So most guidelines of CKD, these they classify based on three parameters. One is cause of the CKD, then EGFR and albuminuria. So all are important, but I would give more importance to proteinuria because it is more easy to estimate. And in very early stages, you can diagnose it. You can, at the stage when there is still hope that you can reverse it. So albuminuria is most important assessment as compared to the EGFR. It is also very useful diagnosis in DKD to monitor the response to therapeutic interventions. So if you have put the patient on RAS inhibitors or maybe Findranon, and if there is a significant drop in USER, patient gets quite encouraged and he then adheres to the treatment. And it also encourages the patient, along with the patient, to the doctor also. And if at the time of diagnosis, if there is a very high proteinuria, it is a poor prognostic implication also. So albuminuria definitely is more important in early stages of CKD.
Quite true, and I think thank you very much, Dr. Sonu, for highlighting the importance of albuminuria. And I think you very rightly pointed out, if we are able to demonstrate that the drugs, and especially a whole lot of them available to us today in our kitty, can make a decisive difference in the way the progression can be halted, I think it adds to the confidence, both as far as the patients and their families are concerned, but it also gives a sense of accomplishment as far as we as clinicians are concerned, because for good about 30 years, we had nothing beyond RAS blockers, and suddenly we have a gamut, we have a whole lot of molecules which can certainly make a difference. But thank you very much. And I think we will move on to Dr. Arvind. And I think with his experience, Dr. Arvind, I would want to know from you, as Dr. Kulwant had said, the diagnosis is at times made in good 50% when the patients have already reached a very late stages of their CKD. So what can be done to pick up these patients at the early stages? Because we know if you pick them up young, it is going to make a huge difference from the kind of treatment that we've been talking about. So what would be your advice, and how should the primary care physicians, because we know the patients come to us as nephrologists rather late. It is basically a collective responsibility. For years and years, they are going to be with their trusted physicians whom they can relate to. So how would you advise the physicians to be vigilant about while suspecting CKD in their patients? Dr. Arvind, please.
Good evening, sir, Dr. Kuller. Good evening, Dr. Dalal. Good evening, Dr. Chakravarti. Good evening, Kulwant Singh. Dr. Kulwant Singh's lecture is very eloquent and decisive for the diagnosis of CKD. Actually, the problem of CKD is basically we are in the field when the kidney disease is very advanced. So it is only the primary care physician who can be involved in this, and these primary care physician faces the primary CKD. I am saying the primary CKD because they are the most exposed to the general population, and when they are exposed to the general population, they are coming with various kind of kidney disease. So for primary care physician, we suspect chronic kidney disease when there is a risk factor. What are the risk factors? Risk factor is hypertension, diabetes, family history of kidney disease, or prior kidney injury in same patient who is coming up. symptoms of fatigue, edema, changes in urination frequency, color, volume, and nocturia. You will appreciate me that our older teaching is nocturia is the earliest symptom of CKD. In our old book, it is written. If we examine the physical examination, that we don't have much to find in the body. That is only the blood pressure reading, which may be sometime raised or devastatingly raised in chronic glomerulonephritis and may be low or may be hypotensive patient in the patient of chronic interstitial nephritis. Edema definitely should not be missed by primary care physician. We have three main causes of edema. That is, one is the hepatic, one is the cardiac, one is the renal. If hepatic and cardiac is ruled out, then definitely this edema is a renal. Again, second important point which we must emphasize that this hypertension, diabetes, family history is also important. If the patient is having family history of the diabetes and hypertension, suppose in the parents, then the chances of getting diabetes and hypertension in offspring is much more high. If parent is having hypertension, diabetes with kidney disease, then the chances of having diabetic nephropathy in offspring is very high. So these are the some framework which we have to consider, and the specific regional factors presently that's coming out as a water potability, pesticides, these all have to be taken into the history, and all we have to examine first. That is the membranous nephropathy now coming up is that is the fairness cream is the unfair to us that contains the mercury. So that is becoming a one part of the CKD. So these kind of evaluation which has to be pertinently goes in the field of primary care physician.
So quite appropriate. I think you very nicely summed up, and I think it's the onus is on us as physicians not to miss the presence or absence of a chronic kidney disease in a patient who is predisposed to. We'll be doing a big disservice to our patient who's a diabetic and or a hypertensive who comes to us or had a history of acute kidney injury in the past, and we forget to estimate the GFR or the albuminuria. So these are some of the very basic tests. I think we should refrain from saying that they are expensive tests. They are not. And okay, for that matter, even if albuminuria estimation is a bit expensive, I don't think it's a terribly expensive proposition, because what you can the kind of difference you can make if you catch them young is, I think, this would appear to be peanuts as compared to the advantages which you are going to accrue. So absolutely spot on, and I think this is something which we should always keep in mind. It may or may not be there, but I think it'll be our responsibility, moral responsibility of each and every one of us to investigate the possibility of chronic kidney disease, especially in those who are predisposed to it. So with that in mind, Dr. Bhatt, this question is for you, a very, very relevant one. We have been talking about estimated GFR. So obviously, and since we are not talking about creatinine, we could have said, Kulwant could have said, okay, get their creatinine done and label in them as having chronic kidney disease or not. But he has not said that. The KDIGO guidelines, the heat map says that, okay, you must classify your patient based on that heat map. And then they have number 1, 2, 3, 4, which means the times you should investigate them over a year. A person who has one, you need not bother. Maybe once in a year is fine, even if he or she is a diabetic. But if the number 4 is written in that box, obviously you have to be getting their test done much more often, at least 4 times in over a year. So my question to you, Dr. Bhatt, would be, why would you believe that it may not be appropriate to reflect on someone's kidney function via serum creatinine, and why do we need GFR, or for that matter, the matter should not finish just at estimated GFR? For practical relevance, yes, we do believe that estimated GFR is the way forward. May not be ideal, but then a lot better than creatinine. So why so?
Thank you, Dr. Kular, and good evening to all. And my good wishes to and happy birthday to Dr. Raj. And coming to the question, I would say that Dr. Kulwant has initially explained things very well. Serum creatinine truly doesn't reflect every time the kidney function of a person, especially in the settings of where there is the muscle mass is affected, like in the extremes of age. Somebody is athlete with a good muscle mass, his creatinine may not reflect his actual kidney function. Same is true with those who are cachexic or who are malnourished. We may get a false reading there, though their creatinine may be normal, still their kidney function is already deranged. So in all the settings, it is definitely correct. Initially for evaluation, we do GFR estimation, but considering the patient's condition, what he is, we have basically to apply our clinical knowledge also. We have to see the patient's condition. Then accordingly, one is we have to estimate GFR again then. We follow the patient, we may do, in certain situations, you may go even for the measured, which is very rare, but estimated GFR you have to do in a patient and then follow it with it and see his symptoms, collaborate with his other conditions. If he is in a high risk group, then we have to definitely follow him and see what happens to the GFR. If we have an estimated GFR at initial stage of 60, then we see it after say 2 weeks or 3 weeks. We have kept him on the radar. We have asked him to follow up. Then we check it again. If it is worsening or it is still there and we have a clinical setting, I think it should alarm us that the patient needs to be followed up. He needs to be taken care. He is a CKD.
Very nice. And I think this is a very loud and clear message which Dr. Bhatt has given. And I think this is for everyone to remember that we need to evolve. I mean, there were times when we were criticizing that a proper, reliable creatinine is not available at most of the centers. Not any longer. I'm not saying it's a universal statement, but our country is much, much better than where we were till just about 2 or 2 decades ago. So that brings us to very interesting, important. Of course, we don't need anything more when it comes to estimating the GFR. The creatinine value is something which we are going to rely on. All that you are required to feed in is the age and the gender and the race of the patient, and you get the value in front of you. So I think we just need to be a little less clumsy in our estimation, in our reflection of a given patient CKD. These apps, as Kulwant had said, are widely available. You just need to get rid of this inertia and do it for the sake of your patients. So Raj, at this point in time, and Kulwant had given us a very, very scary kind of information that there are far-flung areas in our country, even today, where the reliable tests are not possible. So why not go in for the way we are doing it with our glucometers? So you might contest they are not 100% accurate, but they're reasonably accurate. So at least we have a decent idea about what we are talking about. Do you think these point of care testing devices are the need of the hour, especially in our country and especially in those far-flung areas where so many times, or even in the areas which are not resource constrained, you may want to give an information to your patient right then and there itself when he or she first presents to you that, look, you are a diabetic and you have possibly chronic kidney disease. Obviously, as the definition would say, we are not going to label them as CKD on day one of an abnormal value. You yourself said there has to be a proof of chronicity, but then at least you need to sensitize them to that. So do you think these point of care devices are robust enough, are reliable enough, and the need of the hour? Raj?
Share our experience. In the last 2 years, we have been using point of care testing. It's just like what Dr. Kunal said, a glucometer in our emergency area. And the serum creatinine that comes up on the point of care meter is 0.2 or 0.3 units more than what we get in the lab. So we have done it multiple times in the last 2 years, and we have found that it is close to the lab value, maybe 0.2 or 0.3 difference. So I fully agree with Dr. Kunal and you that India today should have point of care testing, and this particular machine that we are using gives at the same time hemoglobin, sodium, potassium, creatinine, of course the pH and bicarbonate, almost everything, including calcium. The only thing it doesn't give us in a kidney patient is the phosphorus and uric acid. So I believe each one of the units should validate these point of care testings, and it will be extremely useful. Coming back to in the community, the amount of CKD that we have found, as you are aware, we had done some studies in the urban slums of Hyderabad. We got it at 14.8%. But when we got some of these people to the hospital, we found their creatinines had come down. So when you do a horizontal screening in a community, sometimes even acute kidney injury you are picking up as chronic kidney disease. So that could be one of the fallacies of a one-time horizontal screening in a community. We should follow up these patients, and only when you have a repeat creatinine or GFR or protein loss should we be labeling them as CKD.
Well, thank you very much for that information, and I think this gives us some confidence that yes, when you practically have nothing to offer to our patients in the far-flung areas, these devices certainly can come to the rescue of these patients. You can have on-the-spot diagnosis made. Then at least rather than waiting for 3-4 crucial days to get sensitized to the absence or presence of a given disease, you can act faster. Dr. Sunal, we heard about cystatin C. I am not going to advocate the routine use of cystatin C, but the way you see, we take pride as Indians that we are with the times. We as physicians are definitely, our knowledge is at par with the best anywhere in the world. Why should we refrain from taking up things which are not so futuristic at the same time? We have been hearing a lot about cystatin C. So on one hand, we do understand there are fallacies, as Dr. Ashraf Bhatt has also told us that there are limitations of what we can derive out of serum creatinine value. So don't you think we should not stay away from the concept of cystatin C, because we do understand that this can come to our rescue when we have some peculiar clinical situations where it can make a difference. So my question to you would be, the newer guidelines of KDIGO, and we all as know, are sacrosanct to all of us when it comes to forming our opinion about the various diseases pertaining to the nephrology world. So the recent guidelines, they talk about estimating the GFR category using a combination of creatinine and cystatin C, especially if cystatin C is available. So please don't take me wrong. I'm not advocating the routine use of cystatin C, but I am proposing that yes, whenever in doubt and whenever facilities are available, because you see, we are not going to limit our discussion to those far-flung areas. We are joined in by the physicians who cater to those of the Indian population who have all the right to get the best possible care. So would that really make you believe that the newer KDIGO guidelines are in sync with our needs in India, and we should, on a case-by-case basis, also keep cystatin C-based or a combination of creatinine and cystatin C-based GFR estimates to make a correct diagnosis?
That's true. Actually, we have moved from creatinine to eGFR, and now it is the time that we should move from eGFR, which is based on creatinine, to eGFR, which is based on cystatin C. Basically, the recent 2024 guidelines of KDIGO says that we have to confirm eGFR by at least two methods, either based on creatinine or cystatin C, or best is to have a combined method which takes both creatinine and cystatin C into consideration to estimate the GFR. As a most important thing in this is that GFR estimation is important to decide the mortality and medication eligibility and dosing. So sometimes a patient who has been having EGFR based on creatinine around 27, and the same patient, when we estimate GFR on the basis of cystatin C, it may come to 35. The difference is only 7, but that patient would otherwise would be not given important drugs like RAS inhibitor or SGLT, or if there is some important clinical trial which is coming, he would be excluded. So it is very important that we should do the EGFR estimation by both the methods. And if there is a difference of around 15% in two methods, it is acceptable. But if there is a variation of more than 15%, then we have to rely or more on the cystatin based EGFR rather than the creatinine based EGFR. As we know that the creatinine based EGFR vary with many things like muscle mass, age, sex, race, then protein intake, and liver diseases, HIV, so, and some drugs. So based on these so many factors, it is getting varied. So cystatin based EGFR is more accurate, but best is to have combined uh, both cystatin C and creatinine based CKD EPI.
So very, very important message which Dr. Sonal has given us today. And I think, as I was referring to, why deprive of our patient population of the best which the contemporary nephrology science is able to offer to them. So with that in mind, and what we have heard before, Dr. Arvind, my question to you would be: we know that there is a decline in the physiological decline with advancing age. We know that our patients lose 1 ml of GFR per minute on a yearly basis. So obviously, we are going to find a difference between the GFR in a young, an absolutely healthy person, and an elderly who could also be healthy, who could be for the given age, an elderly person in the age of 80. So how would you make a diagnosis of CKD in a patient who has some comorbidities by going by that value of GFR, which, as I said, may not be age appropriate. And now we are talking about, and I'll give everyone an example. When we, and I'm sure Dr. Arvind and others experience the same kind of situation, when we screen our donors as potential donors while we are about to perform a transplantation, you will be amazed to see the kind of GFRs we come across. So it could just be about 70, 75 at an age of about 60. I don't know how should we take it. We have been thrust upon the values which are typically seen in the Westerners. We need to, of course, have our own normograms, but at the same time, what we are talking about today is the age associated decline in the renal function. And of course, we have to adapt to that scenario before giving any statement. Dr. Arvind, how would you diagnose a CKD in an elderly population is the crux of the question I'm wanting to ask.
Actually, sir, in the patient who is senior citizen or having multiple comorbidities, then we have to have EGFR considerations, comorbid impact, and comprehensive assessment. It is not just only the EGFR by creatinine method or cystatin C method. We have to consider the holistic as far as senior citizen is concerned. Sorry. So, as far as the senior citizens are concerned or patients with comorbidities, we have EGFR consideration. We have to use age-adjusted EGFR formulas. As the muscle mass decreases with the age, potentially leading to the lower serum creatinine, and that might underestimate the kidney function. Comorbid impact: consider how conditions like heart failure and liver disease, along with the patient with the kidney disease, that may affect the kidney function and the lab result. So, comprehensive assessment to incorporate thorough history, physical examination to identify the sign of kidney impairment beyond the standard test. Vis-a-vis, we have to also consider the heart function and liver function. then only we can assess the kidney function in the patient of multiple comorbidities. Then again important is the interpretation of laboratory results, especially serum creatinine. A creatinine-based eGFR will overestimate GFR in elderly population, especially doctor has said that sarcopenia. When there is a sarcopenia, then there is a decrease in the serum creatinine that overestimating the GFR. So whenever there is sarcopenia, then we have to have the urine ACR, which doctor has suggested that urine ACR is important. Furthermore, the presence of frailty may alter the treatment target. Recommended for younger patients with CKD that may not be necessary to transferable to the senior citizen. Strict BP lowering, which we have, KDIGO has suggested that a below 125 by 85 and below 120 by 80, that may not be possible with the senior citizen because they may get dizziness, postural hypotension, orthostatic hypertension, and they will land into the other complications like fractures and bedridden state, bed sores. So frequency of testing is also important. Management consideration is also important. Medication review is also important, whether drug interaction is there or not, or what are the liver status, what are the cardiac status, and one more last, that interdisciplinary approach is important. Unless we got an interdisciplinary approach with geriatric physician, with nephrologist, and with the primary care provider, unless we all three or somebody else which is involved as a cardiologist or neurologist or other hepatologist, then we have to have a good uh, estimate of the function of the kidney. Directly creatinine and eGFR and cystatin GFR is not advocable in these kind of patients. Thank you.
Quite true, Dr. Arvind. I can't agree any more with this, and I think that's the reason why I asked you this question. I think, as I said earlier, we need to evolve. We knew the fallacies with creatinine many years ago. We came out with formulae like Cockroach Gold formula, and then the MDRD formula, and then finally we had the CKD epi, and now finally, as Dr. Sonal has told us, the importance of a combination of creatinine-based and cystatin-based GFR, this thing. So we have to keep ourselves abreast with the latest in the contemporary knowledge, and rather than the word which we used earlier as well, sucking away from our collective responsibility. So with that in mind, and I think we are of course running short of time, but then few very important questions are still there, Dr. Ashraf Bhatt. So how would you help the physicians handle cases of diagnostic uncertainty in CKD, especially when there are just borderline lab values or one unclear symptoms in your given patient? So how would you help your friends across who have joined you today to help them with overcoming these diagnostic uncertainties?
I think this is a very relevant question because these are the cases which they mostly come across. And what I would suggest them that it needs a systematic and a patient-oriented approach. They have to first go to the basics. Go take the detailed this history of the patient, and with detailed history, which means you have to go to their family history. Other thing is whether there is anybody in the family who has had a CKD, and then other history is hypertensive, and go to his history of drug intake, what he has been doing. Has there been any in the past any such insult which could lead to CKD in the later stages of life? And then we have to take also into consideration that check him thoroughly, examine him thoroughly, see whether there are any signs of CKD in the patient. Say simply whether patient is some frequent change in the frequency of his urine, he has started nocturia which was not there, or his appetite is affected. From all signs and symptoms, we have to collaborate and then think of whether it is any way pointed towards a CKD, and especially considering if he belongs to a high risk group, which may be whether he has been taking some medication for long, say for arthritis or other things or other medications, whether he has these signs or he has notes these changes in his lifestyle now. I think these things need to be assessed and systematically. Go with the basic tests like urine examination, which may tell us many things which we nephrologists consider as part of physical examination. It reveals many things regarding the kidney. And if there is any abnormality, whether protein or the sediment is abnormal, then we go accordingly. After that, kidney function is which my other panels have elaborated very nicely. We can go to the kidney function estimation by one or the other method or the combination, so that we come to the approach whether kidney function is deranged and it is really a CKD picture. And these things are to be taken. After that, we go to the testing. If we have suppositions and if they keep them with them, because this is what my other co-panelists said, that they land first to them, especially when it is the time we need to intervene. That time they need to be explained that we are asking these tests again. This is for you. This means that this disease is to be fully explained to the patient. His kidney function, it will be a long-term benefit for him, that so that we confirm it is a permanent damage and what stage it is, how we have to approach further. This is how we have to go. And I think then accordingly we prefer these our colleagues physicians who see major chunk of patients. Then if kidney function is much deranged, they should then refer them to the nephrologist, where we then think if it is worsening, whether we go for histopathological examination, we go for the other panels of the exam, these investigations, and treat them accordingly.
That's very nice, very informative, and I think I'm sorry there was a little breach of signal in between, but then I think we could still get your message, and I think that was very appropriate. So I think, as I said, we're running out of time. We'll want to take a few audience questions, and I think let me ask a very relevant question which has been asked by one of the members of the audience today. How can we reasonably predict which patients with early stage CKD are at the highest risk of progression? Because if we have to channelize our resources, we would rather pick up those patients who have higher chances of CKD progression rather than wasting our meager resources to everyone, which certainly I'm not denying that every life is equally precious, but then those who have higher chances of progression. Dr. Sunal, if I may ask you, what role do the genetic factors play in this kind of progression of CKD, and which are those patients of proven CKD, labeled CKD, where you would be more proactive in your advice to the family that, look, you need to be more vigilant?
Yes, certainly. There are certain hereditary and genetic variants which have been associated with increased risk of CKD and its progression. So, like for example, we have this ApoL1 gene, which is more common in Africans, but they are more prone to the CKD progression very fast. Same way, there is polymorphism in genes like ACE genes or AGT gene or KCN. They are associated with hypertension and diabetic nephropathy. Then there are hereditary kidney diseases like polycystic kidney disease, Alport's, oxalosis, which, as Dr. Kulman said, they underscore the importance of genetic testing. And the risk is also important in genetic testing is that we can have a better risk analysis can be done, a genetic risk score can be done. We can test the patients who are having high risk of CKD by testing their mutations and counseling the family. So this is the way we can pick up the high risk patient and give them best care in early stages so that they can be prevented from growing into the CKD later stages.
Yeah, it's quite true. And I think in the context of the commonest etiology, which we in India are also seeing, and that's diabetes, as Dr. Sonal had pointed out earlier. So we need to know, on one hand, whether a given diabetic has a kidney disease because of diabetes, or is it because of factors other than diabetes? Because being a diabetic doesn't make someone immune to all those other things which a non-diabetic can have. So Raj, my question to you, I mean, you see, there were times when we were students and we were told that if during the exam you were to come out with a statement that, look, your patient does not have albuminuria, and yet you are trying to label him or her as having diabetic kidney disease, the examiner, I'm sure, would have failed us till about many years ago. Not any longer, because we know that there is an entity whereby a given diabetic can also have non-diabetic kidney, can have a diabetic kidney disease, yet no albuminuria. So there is an entity where it's called a non-albuminuric diabetic kidney disease. But for the commoner variety, in a given diabetic, how would you want to differentiate whether your patient has kidney disease? And I'm limiting my question only to diabetes because this, as I said, is very common, the commonest and a dreaded this thing. And answering to taking it further from where Dr. Sonal had left, that no two diabetic kidney disease families are alike. There would be one where it takes decades before they reach the end stage kidney disease, while the other unlucky family may have one after the other family member land up with end stage kidney disease within a matter of few years. So my question is the first part to you. How would you differentiate diabetic kidney disease from a non-diabetic kidney disease in a given diabetic?
Yeah, very relevant thing, as most of the physicians will be seeing these diabetics who, by definition, may have some kidney disease. But how do we differentiate between diabetic and non-diabetic? And this diagnosis is extremely important because all the other diseases which are non-diabetic may have a specific treatment. Whereas in a diabetic nephropathy, you may want to control the diabetes, hypertension, and antiproteinuric strategies. So the most important thing is 5 points. One is how long is the duration of diabetes? If somebody is diabetic only last 1 year and they know clearly before 1 year their sugars were normal, we would not consider them having a diabetic nephropathy. Number two, we always look for a end organ damage elsewhere. If somebody has retinopathy, it is possible that they also have diabetic kidney disease, and the same pathology in the vessels you could pick up in the kidney. If somebody has active urine sediment, like a lot of RBCs or RBC casts, that goes against a diagnosis of diabetic kidney disease, as mostly diabetic kidney disease has a bland urinary sediment. The presence of protein loss has been one of the factors that we do consider. Somebody has a very less amount of protein, like less than a gram, or very high amounts of protein, like more than 5 grams. We always want to rule out other forms of kidney diseases. Finally, you also look at whether the kidney size. In diabetics, usually they have a normal kidney size even by the time they reach end stage. So these points could differentiate us from a patient having diabetic versus non-diabetic. So every physician who sees a diabetic with some protein or a creatinine bump up should spend some time looking at, is this just diabetic kidney disease or non-diabetic, and making a proper diagnosis by subjecting them to a biopsy will enable us to treat them specifically. It's quite common to get membranous nephropathy in our population. So this patient may have 6 grams of protein loss. If you label him as a diabetic nephropathy, you may not be giving him the appropriate treatment, and you may be allowing the progression to be much faster. So keeping these points in mind, suspecting that there could be a non-diabetic disease is very important.
appropriate, and I think that's the reason why I asked this question, because not every diabetic is going to have what is called a diabetic kidney disease, where of course we give ACE inhibitors, ARBs, SGLT2 inhibitors, Finrenon, and a whole lot of things, but it could actually be a treatable or a totally recoverable situation, which may go undetected if we do not have that index of suspicion. So well, you are really running out of time. My final last two questions, one to Dr. Arvind Gupta. Dr. Gupta, you talked about helping the physicians make a diagnosis of CKD, and we know that if the disease has been there for some time, it can have an impact on the erythropoietin production and a whole lot of other reasons which can actually cause anemia. So how relevant would you put presence or absence of anemia in while making a diagnosis of CKD in your patients?
Actually, sir, whatever the symptomatology which we get in uremic patient, the most of the symptom, I think I should say that it is 70% or 80% of symptoms are due to anemia. If you agree with me, you may not agree with me, but it is 60 to 70% the symptoms of patient of uremia is due to anemia. And anemia is just such a neglected thing in our country. Then patient comes with anemia, then physician infuse the blood. They don't ever go to what is the cause of anemia, and these patients are probably the CKD patients or systemic lupus erythematosus, SLE patients, which are getting transfused by number of transfusion, but they ever get diagnosed with what is the basic disease. So if you go for CKD, then stage 3, then 10 to 15 to 16% patients are anemic. With the stage of CKD 5, and we have the 50 to 60% of patients are anemic. And this anemic syndrome is actually, we can treat with, we have armamentarium of therapeutics agents, which we can treat anemia, so that we can treat, if we treat anemia, then most of the symptoms of the CKD may go off. And we have plethora of drugs we can use in the combination, we can use in the other formulation. And what we need to assess, to what we need to say that with the primary care physician, then we should not forget the basic approach to anemia, where we have to rule out vitamin B12 deficiency, we have to rule out folic acid deficiency, we have to rule out vitamin D deficiency, which is coming out as a hazard. I think in the phases of the COVID, vitamin D deficiency has come up, which is the vitamin D deficiency that COVID patient did not fare well. So reticulocyte count, hemolysis. Hemolysis is very important in the patient. So we have the plethora of treatment to treat anemia just when we cause when we get the cause of anemia.
Yeah. So quite relevant, and I think you have very rightly pointed out the importance of anemia, and that is why we as nephrologists have been fascinated what has been thrown at us via the important weapons which can ameliorate anemia in our patients of CKD. Kulwant, one question to you. I know we've been unfair to you for the paucity of time, but then one concept you talked about CKD, and we know if a patient has renal insufficiency for the first time, it could well be AKI, which should truly be taken care of within the first 1 week. And then you label as someone having CKD when it persists for about 3 months. But now we know there is an entity called AKD, which typically talks about the clinical situation between 7 days and 90 days. We don't know which way we are heading. We can come back, patients can make total recovery, or patient may actually head for a CKD. So what kind of strategy would you have in place when patient comes to you with some kind of urinary abnormalities or reduction in GFR for the first time? So how often would you want to recheck so that you are able to confirm or rule out the presence or absence of CKD? Dr. Kulwant.
Sir,
Yeah.
sorry for my apologies. Actually, So actually, sir, we to rule out AKD versus CKD, we have to go to the history. We have to see for any chronicity. We have to review the records, and we can that can actually differentiate between AKD and CKD.
Right.
Other modalities like imaging, kidney biopsies can also serve the purpose to differentiate the thing.
Yeah. So whenever in doubt, we must go in for the more appropriate modalities, the diagnostic tools to be able to convincingly establish the diagnosis. I think we have gone along. We overshot the time, and I think let me try and wind up. And certainly my apologies. This was going on in such an interesting manner that at least I for sure was not wanting to put an end to the lively discussion we've had today over the last about 1.5 hours. So thank you very much. So let me just make a sort of summary that yes, the CKD is very widely prevalent in our country, and it's our moral responsibility to be able to help our countrymen with whatever way we can do, and making a correct diagnosis at the right time of CKD is certainly the need of the hour. We have heard about the importance of EGFR and albuminuria. We have also heard about the limitations of creatinine, and that is why we were in between talking about cystatin C. We have now heard about the importance of knowing whether your patient has albuminuria in a chronic manner or not, because that can actually otherwise deprive them of so many of useful modalities of treatment which we are privileged to have in 2024 for our patients. And we've also talked about the importance of picking them up at the right time, confirming the diagnosis with the various tools of diagnosis which we have in our armamentarium, and certainly it can play a big role in the way we treat CKD, and something which we are going to discuss in our future editions, picking them these symptomatologies, these signs and symptoms, and the typical form of frustrae of CKD in our future editions. But for now, I would want to thank you, the speaker for the day, Dr. Kulwant, and all four elite panelists for a wonderful interaction and the kind of knowledge which they disseminated. And I'm sure the audience would certainly have found it very useful to incorporate in their daily practice schedule. Thank you very much. Over to you, Dr. Nishan.
Thank you. Thank you very much, Dr. Kular, for sharing those learnings. It was indeed an intriguing session of this inaugural episode of the new webinar series Nephro Live, for which we are so excited. And we could not have asked for any better inaugural session to this very important clinical topic. So while the time is less, I'm tempted to just speak one line which I have read in one of the forums, that diagnosing CKD is like reading between the lines of a complex novel where each test offers a new chapter or some new character, but the real story is always hidden in the subtle and most importantly conflicting details, with which we had so many questions which our allied panelists and everybody answered. So for that, I would like to express my sincere thanks to all the four panelists, Dr. Sonal Dalal, Dr. Arvind Gupta, Professor Bhatt, and Dr. Chakravarti. My sincere thanks to Dr. Kulwant Singh for sharing these wonderful insights on the challenges and the management practices. And my heartfelt thanks to Dr. Dinesh Kullar sir for those wonderful insight, moderation, and making sure that to share take-home messages with each and every question. And I'm sure with this new format, our audience must have learned a lot, and this will surely help us in their day-to-day clinical practice. And I am happy to share that we have crossed around 2000 numbers as a logins for today's meeting. So this shows us that we are continuously receiving the overwhelming support for this particular forum. So my big thanks to all the audience, and we look forward to your continued support in our next episode on this very important webinar series as well. So with this, once again, thanks to all the faculties, and on behalf of Intas Zenit team, we would like to sign out of today's meeting. Thank you all. Good night.
Thank you very much. Good night.